I will say good afternoon to those of you that are here in the UK, in Europe, in and around Africa. I will say good evening to anyone that's further to the east than that. And I'm going to say a very, very warm good morning to Bob and to anyone who is on the far side of the pond right now. So good morning to you, sir. How are you?
Things are good and great. Just trying to wake up a little bit early here, but happy to be here.
Splendid. No, we're always grateful. And we know how early it is over there. So thank you very much for your time and commitment. So as ever, Bob is here to answer your PBC questions. He is not here. I'm speaking about you, Bob, not to you now, but Bob is not here to give you precise or specific medical advice. But we will do the very, very best we can to give you generalized medical information. Again, this conversation here does not take the place of your appointment with your consultant, but what we hope we can do is empower that conversation with your consultant. So you know where to go, you know which questions to ask, and you know how to get the best possible care for you in your PBC journey. So, Bob, I don't have PBC. You know my mother does. I don't believe you have PBC. But we were both in Milan very, very recently, being an active part of the PBC journey. How was that for you?
Well, of the three major foci of the event, I would say PBC is in the top three for all of the activities that went on. And awareness, new therapies, testing, managing pruritus were all super hot topics. It was just an amazing meeting for the PBC world and ultimately for our patients who we're here for.
Yep, perfect. Thank you. Any takeaways, any exciting moments, anything that really is going to either change your thinking or change your practice or anything you really took deep inside?
I think that on the positive side, we have two new therapies. One just was approved in the US, and maybe you can tell us about the EMEA for elafibranor, and we're expecting approval in the US for another medication mid-August. So that's amazing. Two PBC medications in the same summer when we've had no new therapies since 2015 when OCA was approved. And I think it was 20 years before that when urso was approved. So the timeline is compressing thanks to patients, investors, companies who want to make a difference.
Absolutely. So, yeah. Okay. So we did a special. Okay. First question live. Is the second one seladelpar? I think we can say yes to that, can't we?
Right. We just use the names, I think, for both these medications.
Yep. Okay. Perfect. So, yep. So elafibranor was licensed conditionally on Monday in the US only. Now, there are, I feel like Charles Dickens, it's the best of times, it's the worst of times. It's 2024, and we're still insisting on placebo arm trials and all the other stuff that goes with that. But I'm not going to go there today. But what we have is, an enormous potential to make a difference. So elafibranor is through one hoop already, and then seladelpar, we believe, is close to jumping through a number of hoops around the various regulators. So the main regulators that seem to have an impact on everywhere else is the FDA, which is in the US, the EMA, which is the European Medicines Agency, which was in London and moved to Amsterdam. We won't mention the B word, but that did change things. And because of that B word, we now have the MHRA in the UK. Any other? Now, I'm going to use the term HTA. HTA is a health technology assessment. And this is, the type of organizations that do this work to make sure that medicines are safe. Are there any other HTAs that play a major role in this kind of thing around the world?
That's a great question, but I think Great Britain is leading the world with that technology, because usually the FDA hardly mentions cost or cost effectiveness, even though in their called in their script, in their minutes of their meetings, they want cost effectiveness and they want quality of life information. That usually does not come into the final equation. And the EMEA, I think, also does it, but they don't go through what happens with NICE at the level that I understand. Maybe you can correct me about the EMEA, again, weighing in cost effectiveness and cost of a drug. So I've seen medications turned down in Great Britain that were approved everywhere else just because they didn't think they were cost effective. So it's a new filter, and we'll see if the other major regulatory agents make that move. Am I answering that correctly, Robert?
Yeah, all information is helpful at this juncture. So it's always, every one of us will learn something new, I hope, today. So thank you. No, that's good. Okay, right. Let's move on to some PBC questions then. He says right, here we go. So this will be new information to you, Bob, but I was newly diagnosed with PBC in March. My bloods, my alk phos is still 135. All the rest are normal. FibroScan normal. Just had my bloods done again after 3 months, and everything's normal except my alk phos, which has gone back up again. So it's not a huge jump. It's 135 to 167. So I'm going to ask you about consistency within LF, within liver tests. Actually, let's start off. What's the difference between a liver function test and a liver enzyme test? And then we'll talk about alk phos in this test. So that's my first question to you today.
You are prescient, predicting the future, knowing the future, that we should always start with this discussion because providers and patients are very confused. One of the reasons is people use the term LFTs. Well, usually they mean liver enzymes. They don't mean liver function tests. So we're trying to get rid of that LFT completely and say liver biochemistries, liver tests, liver panel. And then you split that into true function tests like bilirubin and enzymes, of which in PBC, alkaline phosphatase is the most important. I think GGT is equally important to alkaline phosphatase in PBC. And of course, AST and ALT are important as well. Back to function, we have bilirubin. I like direct bilirubin in all my patients with PBC and most patients in general, unless the total is in the low normal range. And also albumin, a clotting test called an INR. And there's other function tests beyond that because the liver does about 200 things every day. So when you're talking to your providers and providers are talking to patients, they should use liver biochemistries and then specify whether they're talking about enzymes or function. I think that keeps it simple. Robert, what do you think?
No, absolutely. I think it's a nice way. I often talk about liver biochemistry because it then, just by using that word, it demands more detail. And then you can go into, well, what does that mean to you? And then what is it you're actually looking to find out? So yeah, I think that's enormously helpful. And again, it's these tiny little steps forward that are going to be making the difference for years and years and years to come. So you have the big colossal changes that have a huge impact, but actually just piece by piece, just getting better in what we do on a daily basis, I think has an impact. So thank you for that. So we're going to now come back to me, who my alk phos now has just gone up from 135 to 167. So everything else is normalized, and yet this test has jumped up. Should I be concerned?
I will make a general statement that the higher the alkaline phosphatase, the worse the liver disease and the worse the prognosis. But this is a small change, and there's other things that can change alkaline phosphatase, including bone issues. Remember, alkaline phosphatase comes from liver and bone. There's a few other organs as well. So I would ask any individual patient or provider who's describing an alkaline phosphatase trend or change to make sure to tell me what's happening with the GGT. For instance, the alkaline phosphatase may go up and the GGT is coming down. That's really good news for the liver. And then I'm going to go and look for what could be happening in the bones. Is the vitamin D deficient, which is very common in PBC. So small change. I would continue to do a trend every 3 months. If it keeps going up, then urso is not sufficient. And we would then be talking with patients in general about second line or even third line therapy. But we're going to have so many good second line therapies. Third line won't be in our tool chest predominantly until that third line gets approved.
So, okay, perfect. Now, I'm going to ask a question with regard to, we talk over here in the UK. Now, this is because we have different labs, we have different staff members at different labs, we have different staff members at the same labs, and not everybody can always get the same result with the same machine. So we talk about something called standard deviation over here. And so I think within ALPFOS itself, I think the guideline it says is around about 15% standard deviation. Is there anything you can tell us about that, please?
Well, I think you're right. There's two standard deviations. One is the deviation in the laboratory, what enzymes are using, what assay they're using.
Yeah.
And then there's patient deviations. Just day to day, our enzymes go up and down. So and they may multiply each other. So one change like this, that's not enough to take an action, but to start thinking a little bit more.
Okay. Perfect. That's really, really helpful. And I think, again, it's just about looking at the trend in general terms, as opposed to necessarily being worried about one number at one moment in time. Okay, perfect. Okay, now, over a period of time, I have developed light-colored loose stools, raised cholesterol. Once I started urso, my stools have become firmer, darker in color. Does that mean that the urso is working? Does urso cause cholesterol and triglycerides to be removed from the body into the stools? Does that cause constipation?
Yeah, these are new questions.
Yeah.
So most of the things that happen in people's stools is going to be diet related, not urso related. Urso can, in some patients, actually cause a little bit more of loose bowel movements than constipation I've seen, but I've heard that urso can go either way. But diet is just a huge issue. And I wouldn't be tracking color or consistency in terms of what's happening with urso in helping the liver. So, I would set that aside in general. Now, if the blood chemistries, now we're going into cholesterol and triglycerides, are coming down from urso. I've heard that happen. That's not a major event with urso deoxycholic acid. It does not change cholesterol and triglyceride levels significantly. And that's, again, either diet or another medication that's taking place. There are variations. Of course, fasting is going to be lower than if you get those tests done after a meal.
Yeah.
So, but cholesterol is important because people with PBC are at equal risk of cardiovascular disease, not higher risk, even if their cholesterol is sky high. So talk to your providers about what are the indications for cholesterol lowering drugs. OCA can change cholesterol levels slightly. And this whole class of drugs can increase the risk of cholesterol gallstones, although these numbers are 1 or 2%. It's not a big issue. And it's not really clear if it was these gallstone issues are going to happen anyway. But there is some hint that they may be a slight change with these different medications. And we'll have to wait and see what the final data is on elafibranor and cilalopar. I believe both of those PPAR drugs, that's the class of drugs, Robert, PPAR, might provide a more favorable cholesterol profile than what we see with OCA. But OCA has not been associated with any cardiovascular events. And almost all of my PBC patients are on statins because I think statins are liver protective. They have an anti-cancer effect, as well as cholesterol lowering, as well as helping cardiovascular risks. So there's a lot going on with these different medications and things we need to watch. That's why patients need to be in a partnership with their provider.
Yeah. Okay, perfect. That's helpful. Right, we just had a message, but It's really difficult to make out the accent. Wait a minute, what does it say? Oh, wait a minute. It says hi from Wales. It took me a while to work out the accent. So I just thought I'd share that with you. Live question for you, and I'm not entirely sure I know what this means. So if we need to go back for clarification, let's do that. Is an M2 positive result greater than 100? I'm assuming that's 100%, but greater than 100 clinically significant? Oh, wait a minute. Oh, now I've got it. Is an M2 positive result greater than 100 clinically significant? That's the question.
So M2 is the number one auto antibody that we detect in the blood and make the diagnosis of PBC. That is directly linked to the diagnosis. As you know, you make the diagnosis of PBC with a positive AMA. It's an M2 antibody and a high alkaline phosphatase, although there are people with normal alkaline phosphatase with PBC as well. So the height of the antibody gives me some very subtle information. It's not really a huge important tool at the beginning because the tighter the level doesn't directly relate to prognosis. But if somebody has a level, say, between 20 and 30, that's barely positive. Less than 20 is negative.
Mm-hmm.
This is what's called international units. I may want to follow that titer again in a year or two to see if it's going up, because there is something that some of our colleagues describe as false positive AMA tests. False positive means that AMA is positive, but the patient doesn't have PBC. Those are usually low titer. That's that 20 to 30 range.
Yeah.
But I don't call it a false positive, Robert, until I've followed a patient for 5 years. And in 5 years, they've never shown any type of liver disease by blood tests or by imaging. Then I would call it a false positive 5 years later. Otherwise, maybe somebody who's going to develop clinical PBC, clinical meaning something that's going to be important to the patient and the provider in managing a patient.
So, all right, perfect. That's helpful. I appreciate that. Thank you. I'm going to finish the last question, if I may, because there's something I didn't ask you about. Is there any link between parathyroid hormone, antiphospholipid antibodies, which I believe are linked to lupus? Are they linked to PBC, and could urso have an impact on those?
This is a phenomenally complicated question, which I will try to make simple.
Thank you.
So the parathyroid gland sits next to the thyroid in the neck, and these little tiny dots secrete hormones that balance calcium and bone health. And the thyroid hormone, the parathyroid hormone interact with each other, but the parathyroid hormone is something that can cause the calcium level in the blood to be quite high, but more importantly, the alkaline phosphatase to be very high. So every year, 1 or 2 patients I diagnose with hyperparathyroidism. That means an overactive parathyroid, because the alkaline phosphatase is sky high, 400 or 500, and the GGT is normal, 20 or 30. So then you know it's coming from bone, out from the liver, and this is the number one cause. So lowering the parathyroid hormone will lower the alkaline phosphatase and will improve bone health. Let's switch to antiphospholipid antibodies. This is another class of tests that relate to an antibody that goes against what's in our cell membranes. But these antibodies, when they're high, can be associated with clotting. But the link to PBC is when you have primary biliary cholangitis, you can have a variety of other autoimmune syndromes. And this antiphospholipid antibody is an autoimmune condition that results in clotting, excess clotting, and importantly, can be related to lupus. There's something called a lupus anticoagulant, and there's procoagulants in this world. So the basic message is when you have PBC, your providers need to be monitoring you for a variety of different illnesses, parathyroid disease, clotting disorders, other autoimmune conditions. So everything you say as a patient to a provider is important. It should be important to the provider. And that's ultimately, you need to connect with a provider who understands and listens to what you're saying.
Perfect. Thank you. I appreciate that. Okay, we're going back to, actually, let's move on to Parkinson's related cirrhosis. Do we have any advice? Do we have any knowledge?
This is Parkinson's disease you're asking?
Parkinson's related cirrhosis is the question.
I have to, is that on the sheet of paper that you sent to me? Or
No, it's a live question on Facebook. Somebody's just asked me. Parkinson's related cirrhosis, question mark. Do you have any advice?
So the issue of Parkinson's disease and liver disease, if I'm getting the question correctly, or Parkinson's disease and cirrhosis, there is not a direct link. There are indirect links in that people who have chronic liver disease may have a slightly increased risk of Parkinson's disease.
Okay.
There's no direct linkage that I know of. And if there's any reference we should be looking at, somebody can put it in the chat.
Yep. Okay, we'd be grateful. Thank you. So if you ask that question, if you want to come back with more detail or a secondary question, then feel free to do that. And we'll do the very, very best we can. Okay, we're back to right now. Okay, right. Bob, you've known me many years. I'm in a quandary. And I'm in a quandary because I've got a patient that said I would rather try fenofibrate or elafibranor than OCA first. And there's a little bit of my kind of heart raced there because, fenofibrate has not been long-term tested for safety signals and all of those kind of things. And OCA's gone through quite a very specific dance to get its license for PBC. And as a patient advocate, I do have my concerns in around, when to use licensed and unlicensed therapies. So I just had a little bit of a heart flutter there. So I'm saying that in full disclosure, and then we'll go where this conversation takes us, and let's see what happens. So again, somebody's ALP is up. ALT is now up to 59. Normal is 30. AST is right on the cusp of normal as well now. Should I ask for my GGT to be tested also? And if my numbers aren't going down, will my doctor start me on second-line therapy? And what can I do in terms of requesting my second-line therapy, or do I have to try OCA first?
Important question. So, yes, as liver enzymes are assessed, every liver panel, in my opinion, should have a GGT, and every liver panel should have a direct bilirubin if the total bilirubin is greater than 0.6. So everybody in our community, medical community, should be using that. There has been some pushback from liver specialists not to use GGT. Oh, I never test for it. I don't see a use for it. But every time I present to them the importance of GGT, I can get people to switch, but these people just don't think about it. So ask your provider for a GGT and a direct bilirubin. That's a summary to everybody on this call, everybody in the PBC world. Then if liver tests are not improving, I bring one more factor, Robert, into the equation. Of course, I want liver tests normal. That's the bottom line. But I do an elastography test every year. I had 2 patients in clinic 2 days ago as examples. And this happens in my clinics every other month, who had PBC, elevated alk phos, documented AMA positive, who had no fibrosis, F0.
Yeah.
That's 2 in 1 day. And these people, at least for the time being, are what we call non-progressors. So they're all on urso, and every year I'm going to do a fibroscan. And if they're marching from 0 to 1 or 0 to 1 to 2 or 1 to 2, I'm very likely to be adding second-line therapy. Then how do we decide on second-line therapy when we have 3 medications on the market, which is going to happen in a little less than 8 weeks. Then the question is, how do you make that decision? I've treated over 80 patients with OCA. I've only had to take 2 off therapy out of 80. There are side effects such as itching in some patients. I think that's very manageable. We've got great medications to manage itching. And we do have 7 years of data, safety data, efficacy data with OCA, which we don't have with any of the new drugs, right? The new drugs are just getting approved on what are called phase 3 studies, short term, they're getting conditional approval. So then I'm going to bring something else into the equation. If I've got a PBC patient who's got terrible itching and hasn't responded to my cocktail of 14 different options for itching, which rarely happens, but let's be hypothetical, then I'm going to be thinking about either elafibranor or seladelpar. And elafibranor has a neutral to slight beneficial effect, meaning reducing itching. And of course, seladelpar, I believe, may get a label for itching because it has a more profound effect on itching as well as on liver tests. So OCA's got this great record of safety and efficacy that comes into the equation, and that should be discussed with providers. And then we have 2 new drugs with much less long-term data, but good safety data, and they've met their efficacy standpoint. And I'm an expert, and next year I'll be using all 3 of these medications. I'm not biased one direction or the other, but that's all going to come into the conversation. And finally, we have off-label, which you brought up, the fibrates. There's fenofibrate and bezafibrate. And there's been a rush to use these off-label, I call them third-line medications because they're cheaper. And they do have an anti-itch effect also. But there's been some very compelling information, especially on bezafibrate, about its benefit for liver disease and for itch. But I prefer to stay on label as opposed to off label, especially fenofibrate in the US has a box warning on it. Don't use in people with liver disease. That doesn't always scare me off, but it's very important to know that this class of drugs is liver toxic, kidney toxic, bone marrow toxic, other toxic, and 1 out of 4 people, David Jones taught me this. David Jones said 1 out of 4 people come off of bezafibrate or fenofibrate because of side effects. Yeah. It's 25%.
Yep.
That's worse than OCA.
Yeah, a lot of muscle pain going around it after 5 weeks. So yeah. And again, we're hoping that the new therapies will be cleaner than that. So perfect. That's helpful. I really appreciate that. And again, a nice level of detail. So thank you. Right, here's a question. I had biopsies on blocked bile ducts and narrowing of the main pancreatic duct. I've never heard of PBC before. As I wait results, is there any way this could be PBC, do you think? So blocked bile ducts and the narrowing of the main pancreatic duct, could those be linked to PBC?
Well, PBC, through the inflammatory process, blocks the super small ducts in the liver. That's where the attack takes place. But you would never see these changes on a test like an MRCP, that's the magnetic resonance cholangiopancreatography, that looks at the bile ducts and the liver and the pancreas. So PBC should not affect the large bile ducts, and PBC should not affect the pancreatic duct. So when I hear those results, if I'm looking at a report, the patient's coming to see me with that type of assessment, I'm going to be thinking of PSC, okay, or another autoimmune condition called IgG4. And these diseases, Robert, overlap with each other. We have PBC with autoimmune, PBC, PSC. PSC can look like other diseases, including parasitic disease, which is rare, but PSC and IgG4 can overlap also. So I think it's super important to know the family family of diseases that are interrelated, and make sure the provider has enough information to come up with the disease or if there's an overlap. So this concept, to summarize, this person who might present with this type of scenario in my brain, I would be talking to their provider about other conditions, the other need for workup.
Yeah. Okay, that's perfect. That's helpful. Okay, thank you very much. Next question here. I love this question. This question is all about living with PBC. I usually take urso in the evening before bed. I take thyroxine first thing in the morning, and I've been advised to leave a gap between this and my urso. I'm going to an evening social event and we'll have a couple of glasses of wine. Does it make any difference if I take urso earlier in the day or later once I'm back home again?
I advise everybody to take urso once a day, not twice, not 3 times a day, once a day at the same time. I'm not aware of an interaction with thyroid supplements, so that would be news to me. I'd have to see how real that data is.
Okay.
And of course, we advise our patients not to drink alcohol. If you've got liver disease, alcohol is not a vitamin, it's not a nutrient. It's an entertainment. It's like buying a ticket to a rugby game. You can definitely live without it. So I would say 0 alcohol is the best.
Okay. Wow. Okay. Right. Okay, but if you chose not to, 0 alcohol, because it's a choice. When would you want to? Would you need to separate your urso from that alcohol intake?
I don't know of an interaction there either. Of course, I'm worried about people drinking alcohol and then forgetting to take their medicine.
Yeah.
So I would say take it the same time every day. That's the most important.
All right, perfect. Thank you. Okay. So I'm going to dance closer to the line. So again, at the risk of having a couple of glasses of wine and then forgetting to take it afterwards, it might be worth taking it on that one occasion before you go out, have a wonderful evening, enjoy every moment that life brings you, and then we go on the next day. Okay. If liver enzymes are raised as a consequence of taking other prescribed medication, should the enzymes return to normal? And how long would this take on average?
So that's another very complicated, sophisticated question because we do have medicines that are liver toxic directly.
Yep.
And that can take 3 to 6 months for the test to come back to normal if that liver toxic drug is removed. And there's a long list of those potential medicines that are toxic. So yes, that could take months. Also, there are medications like phenobarbital, some of the other anti-seizure medications that induce alkaline phosphatase through an enzyme stimulation. So the alkaline phosphatase can go sky high on a medication, but there's no liver disease or no worsening of liver disease. So work that out with your provider. Is it a toxicity? Or are we just making the enzymes higher? And that's why you need that full liver panel, because often the alkaline phosphatase goes up, but the GGT doesn't change, or the alk phos and GGT go up, but the AST and ALT don't change. So you have to look across the whole panel and look at trends and try to keep your medication regimen simple.
Okay, perfect. That's helpful. Thank you so much. Okay, I have been on urso since February. Okay, we're on 4 months. Alk phos is just kind of staying in and around. Gamma has gone down from 320 to 90-ish. Lost a couple of stone. But does the alk phos mean that I am not responding to urso? Should they have come down by now? And I am awaiting my bone density check.
So in a scenario where a patient is seeing a GGT improve markedly, the alk phos not changing much, takes us back to the earlier question we talked about of assessing for other causes of the alkaline phosphatase. In my opinion, vitamin D deficiency is the most common.
Yep.
And when you put people on vitamin D, you can bring down the alkaline phosphatase. It won't affect the GGT, of course. So then hyperparathyroidism would be something I would order in this patient. It's, again, typically an autoimmune process, part of the PBC family or autoimmune family. So Alk-Phos and GGT should move in parallel. I'm going to take the flip side, though, for a second, Robert. I've got PBC patients that come in. Alk-Phos comes down, GGT's going up. I'm going to strongly suspect an alcohol effect. Alcohol can make these enzymes go haywire. Another reason not to drink biochemically. And then I will do a blood test called a PEth, P-E-T-H test. And I tell patients I'm doing this test. I'm not trying to be sneaky. And I tell the patient I'm doing a blood test to show you're not drinking or to show how little you're drinking, when they usually tell me they're not drinking much. And it does give me a quantification of the total effect of the alcohol on their body, in their body. And it's very, very useful test. It's never wrong.
Okay, perfect. Helpful. All right, thank you. Okay, hopefully that was helpful. Next question. Are air flights bad for PBC patients?
Only thing wrong with going on an airplane is that people sometimes get sleep deprived, but the low oxygen, no, it's just like driving to Denver. It's not a huge issue. And the amount of radiation you get in an airplane is about the same as a chest x-ray, so that's not an issue. You can be in close confines, or you could get an infection like COVID or something. So I think everybody needs to be up to date on their COVID vaccinations, of course. But air flights in general are safe. Just wash your hands a lot. If you're concerned, wear a mask, no problem. And go and see your family or take a vacation, wherever it takes you.
Yeah, okay, perfect. Thank you. Now, I've got a question here, and I'm not sure what the answer is, but I'm kind of wondering if I've written down in the words an itch ladder, and wondering if we can maybe formalize a document for the next Bare Facts. But it says, what are the great medications you mentioned for itching? So many doctors don't have any suggestions. Are there better options than rifampicin, which was the only one that worked for me? So again, I just want to be cognizant of guidelines, guidances, the difference between expertise and the general knowledge within internists and gastros, particularly in and around the US. I don't want to be disrespectful to anybody, but I'm very much aware that there are different levels of expertise and experience. So I want to be mindful of that, and then I'd love to have your thoughts on that, please, Bob.
So this concept of managing itching and what road to go down is different provider to provider and guideline to guideline. The first medication listed in the European guidelines is to go on one of these bile acid binding resins. It's like what's in your water softener. It's a exchange resin, and it binds bile acids, maybe other toxins as well. But you have to take that at least 4 to 6 hours separate from your urso, or separate from your OCA, or separate from your new, medications that you're using. It's just getting over some asthma. So there's an algorithm on my website, robertgish.com. It's called an itch algorithm, and I'm updating that every 6 months because I'm constantly learning things. I don't like using these bile acid binding resins. I have some patients who respond great to Atarax. It's an anti-itch medicine. It's been around for 30 years. And that's barely listed in the European guidelines. They basically tell people not to use it. I think that's also a little disingenuous. It's very inexpensive. Low dose could be phenomenally effective for some patients. But I also like using something called sertraline, which is an antidepressant, but it has an anti-itch effect because of the chemical structure. And it also gives people more energy and helps them sleep better. It's kind of interesting. I'm not saying every PBC patient is depressed, but they may be. So it's nice to be able to help with itch, help with energy, help with sleep in one tablet. So I think that's useful. Rifampicin can be liver toxic. It's listed in one of the most common drugs for causing liver disease. So if someone goes on rifampicin, they have to have their liver test monitored monthly, be aware of the possibility of liver toxicity. I've learned recently that gabapentin has a really profound effect on itching in some patients. Naltrexone is another one that we use as an antidote for opiates. opiate overdoses or reversing opiates. But in this case, it's working on certain receptors that are involved in the itch system. Those are kind of the top four. I also like doxepin. That's good for sleep, it and itch. And I like primrose oil, which is over the counter. It's 2 grams twice a day by mouth, not to put on your skin, but you take the pills by mouth. And that is definitely something I consider. So follow these algorithms, work with providers. It's one of the reasons some doctors decided never to use OCA because they were afraid of the itch. I call it, I hate to be a little sacrosanct about this, but I think they're afraid of working. The patient's going to itch. I don't want to get a phone call. No, I think it should be the other way around. You put them on best therapies and help the patient with their itch. And if their itching gets a lot worse on OCA, stop it, switch, get other new medicines coming this summer. So I think providers need to be really engaged with PBC, not be afraid of the disease, not be afraid of the meds. But on the flip side, Robert, the biggest gap I'm seeing is people who have PBC are not even on urso. Number two, they may be on urso and no one's talked to them about second line therapy. Oh, it's not progressing much. The enzymes aren't that bad. I hear this all the time from both patients and providers, or what patients were told. These are gaps. Everybody should be on urso. And if anybody has progressive liver disease, by our non-invasive tests, not biopsy, but the non-invasive test, progressive disease, they should be on second line therapy. The earlier we treat, the better the drugs work.
Perfect. Okay. Are you comfortable with me sharing with you the pruritus sheet?
Yeah,
not sharing it with you because obviously you've got a rough idea of what's in there, but you know what I mean.
I just share that out widely to everybody. I don't know if you want me to send it to you by email or what's the...
I'm linking to it in your website.
Oh, okay, great.
There you go. Right. There you go. That is in there. And I've highlighted that is your sheet on itch treatment. So hopefully that answers that question. Perfect. Thank you very much. Right. Somebody has just said, they've not said I missed the introduction, but they've said I missed the introduction because their question is, are statins safe in PBC?
The answer in general is yes. And statins, when we have a little bit of history here, Robert, 30 years ago, all the statins had a black box warning about liver toxicity.
Yeah.
That was fake news. The FDA and whoever put that on really blew it. The next wave was taking that black box off. That took Willis Madry and some other famous people probably 10 years of arguing with the FDA to remove the black box because it's not liver toxic. They aren't liver toxic except in 1 in 80,000 people. So they're not liver toxic in that general sense. And now we know that statins are liver protective, antifibrotic. They lower portal hypertension, the pressure in the liver. They are helpful for the liver and they decrease the risk of liver cancer. So I use statins liberally, 3 cups of coffee or 3 cups of tea and a statin, that's what'll keep your doctor away, not an apple.
Yeah. No, perfect. All right. Noted. Thank you. Next question is leg pain. Now I'm going to talk about leg pain, but I'm going to throw restless legs in there as an aspect as well. So extremely painful, either or, can be both legs, can be walking, sitting, legs up, laying in bed at night, keeps me awake. Legs are often weak and cannot hold my body weight. Got a DEXA scan next week, but is that a symptom of PBC or something else I should be asking my GP to investigate? Before I come to you, Bob, I'm going to say to anyone who's watching that those two are not mutually exclusive. So first off, not everything you experience in your life will be because of your PBC. But even if it is because of your PBC, that doesn't mean you shouldn't be asking your GP to see if there's anything that can be done for it. So again, I just wanted to highlight that. And then over to you, Bob, for specific information in and around restless legs, leg pain, joint pain, that kind of thing.
All right. So there's 3 interacting problems here. Restless leg, which is a movement disorder, especially at night. People can't sleep. Their legs are always moving. And then number 2 is leg cramps, and number 3 is leg pain. But I think they're all interrelated. They're kind of what we call overlapping circles that are there. And then, of course, I work on what's going to be the dominant issue to a patient. Leg cramps, leg pain, I want to check a magnesium level. I want to make sure the magnesium is in the healthy range, about 1.9 to 2. And if I use magnesium, which is very frequently in my practice, I'm going to be using mag plus protein. Do not use magnesium oxide. So that's super important. Then leg pain also can be from bone issues. So you gotta have to look at the alkaline phosphatase, look at vitamin D, potentially do a DEXA scan, bone density study. So bone disease can cause this type of pain. It's different than cramp, of course. You gotta really, is this leg pain or is it leg cramps? Be very specific.
Yeah.
Back to cramping. Highlands, anti-cramp. Highlands is a name in the US. I don't know if it's in Europe or Great Britain, but there are cramp medicines that contain a very small amount of quinine, cinchona bark. It's an herbal remedy that's been around for maybe 500 years. People have been using it. And this quinine containing material from this tree bark has an anti-cramp effect. It got kind of a bad rap because it can make some of the blood counts go low, but I think that risk is far less than 1%, Robert. So I use this all the time. And then most recent is pickle juice. Everybody's got pickles in their refrigerator. You can take 2 or 3 teaspoons of that, and apparently it has a fantastic effect. It's been published. This is not just a homespun remedy. That has been published that there's something in pickle juice that has an anti-cramp effect. I think those are the big ones. I'll wrap up with restless leg. There are some medications that are FDA or regulatory approved for restless leg. Talk to your provider about that and make sure you're not on another medicine that's causing the restless leg. There are some specific medications like ondansetron that can cause these movement disorders to be worse. Long answer to your question.
Good answer. I like it. Thank you so much. I'm grateful. All right. Supplements. Where do we begin? Do we just open up and just talk about supplements in general?
We could start there. I'm going to state that I check in all of my liver patients, especially if they have cirrhosis, but commonly earlier, for vitamin A, vitamin D3, zinc, magnesium, and selenium. These are the 5 nutrients we can measure that are commonly deficient in people with liver disease, especially cirrhosis, but you can find it earlier. So the answer is work with your provider, get your blood levels checked, and take supplements specifically to target a deficiency. That's simple, that's accurate, but people love supplements, and people are taking lots of supplements every day. It's a $60 billion industry in the United States. I'm going to say very specifically, don't take any herbs, don't take milk thistle, don't take any other plant-based substance without very strict guidance or partnership from your provider, and research the literature. Really, there's no, in PBC world, there's nothing from plants that has been shown to have an effect on PBC natural history. I mentioned itch, which is a plant-based primrose oil, so that's good, but it really should be evidence-based. So finally, be cautious.
Okay, love it. Thank you. That's helpful. Right. That was a lovely summary. Okay, good. Right, we're going to live questions again. So here is my question for you. I have been a non-responder to urso and never offered second-line therapy. Had PBC for 13 years. FibroScan result was recently 14.5. Is it okay to have second-line medication at this point?
So let's talk about liver stiffness elastography. Typically, you get a kPa value, but some machines give a different value, what's called meters per second, or M/S. And you have to look at your device and look at a conversion from a number to a level of liver stiffness. 14 is typically a number that's associated with advanced fibrosis or early cirrhosis. I would say that person in general who I might see or hear about would need to have a full evaluation for portal hypertension. That means
Yep.
dilated veins in the belly, etc. Another good look at liver function.
Yep.
But in general, yes, an early cirrhosis patient could be on second-line therapy after you collect all the data.
Okay, perfect. Thank you very much. If you are the person who asked that, give us a call. Let me see if we can talk to you and help you through that part of your journey. If you are in the UK, you have the legal right to ask for a second line therapy behavior. You do actually, but you also have the right to ask for a second opinion. And so you can easily get yourself referred to one of the ODNs, which is I can't remember what it stands for, but these are the centres in England and Wales that are prescribing second-line therapies in PBC. So you can ask yourself or ask for yourself to be referred there at any point. How long does it take before you can really be judged to be responding or not responding to urso?
The rule is 6 months. You or provider-patient partnership should be testing liver tests at least every 6 months. I recommend every 3 months for the first year. And at 6 months, if that lab alkaline phosphatase and GGT have not had a 20 to 30% decline, I'm trying to make this simple, there's other numbers that people use, then it's time to think about another therapy. Now, let's say somebody's at 800 and you go down 30%, which is a lot. That's going to take you down up to 240 points. That is a very big drop. It doesn't look so much when you're saying you're at 200 and you go down 30%. That might be 60 points. So the numbers are different, the percentages are different, but you should have, again, back to a 30% decline within 6 to 12 months. If not, and there's significant fibrosis, that person should go on a second-line therapy. That's a simple rule. And significant fibrosis is fibrosis level 1 or higher. I mentioned earlier, some people I take care of are fibrosis level 0, which is amazing.
Yeah.
I do want to highlight the PBC, maybe in 5% of people, never progresses. 95% do. This is a progressive disease, and this is what we call step therapy, add-on therapy, second line to first line if there's a progressive liver disease.
Perfect. Thank you so much. When I'm on urso, my alk phos goes up, but when I'm on prednisone, my alk phos goes down. All my other liver numbers are good. I was in 0-1 fib, but I'm now in 2. So no question in and around that. But how would you advise the next conversation to have with your clinician?
So prednisone's anti-inflammatory and can suppress any enzymes. Typically, when the enzymes go down, that means you have an effective therapy. But prednisone is not used for PBC. It's used for other related medical conditions, autoimmune conditions. Somebody on prednisone, I would also be thinking, do they have overlap syndrome? Do they have a component of autoimmune hepatitis? And I'd be really going down that pathway. That's the rare time that we do liver biopsies, Robert, is to determine, do they have another disease besides PBC? So about 20% of my PBC patients get liver biopsies now because I'm quite concerned about fatty liver. Obesity is an epidemic. Fatty liver is an epidemic, and you can have PBC and fatty liver. The biopsy allows you to tease out which is dominant. I'm going to treat both, right? I'm going to treat fatty liver and I'm going to treat PBC. But if the biopsy is PBC dominant, I'm much more likely to go to second-line therapy early. The biopsy shows fatty liver is dominant, I'm going to be doing more aggressive management for their fatty liver, potentially with resmetirom, the new drug that just got on the market, weight loss medications, the GLP-1 class or the GLP-1 GIP class, the dual agonists. And those are starting to show benefit on liver health also. There were 2 studies at EASL that were phase 2 studies, but very well designed studies, large studies that showed a profound effect of these new injectable agents, not just helping with weight loss, but helping with liver health, fatty liver. So lots going on. It was a very exciting meeting in Milan.
No, it was. It certainly was. So, okay, right. So we're out of questions, and we've got a couple of minutes. So I'm going to bang my personal drum, and I'd love to know your thoughts. So there are a couple of caveats and disclaimers. Number one, you and I are speaking one middle-aged dude to another middle-aged dude. Okay, so let's acknowledge that. Number two, there has been an enormous transformation at the congresses where thousands and thousands of people come together, and we no longer just talk about ALK-Phos, but we talk about disease management and we talk about symptom management. And there was a session we were at recently where the question was rice or noodles, as if there was some false dichotomy between the two. And it was like, disease or symptoms. And the answer is you can address both in a clinical appointment. So there's great progress that's been made. And then you see presentation after presentation where you're starting to hear about itch and fatigue, which is great. There was only one slide in one presentation that I saw that really went down the topic of Sika syndrome and how that can have an effect on patients. And I was talking to a couple of PBC patients who were there at the event. And so I decided that my drum for this summer is to normalize vaginal dryness. So, because it's part of Sika syndrome, and patients talk to us all the time about their experience. But I don't know how much patients talk to their clinicians. I don't know how much clinicians talk to their patients. Because when you talk about every single day living with PBC, so you've got the hierarchy of needs. And ultimately you want the disease under control, and then you want to look at quality of life and how it affects you on a daily basis. And for some patients, this can be a quality of life issue. So how do we normalize the conversation? How does it normally happen in your clinic? Is it something that patients talk to you about? And what can we do as a patient community to make that as part of the conversation?
So great question. When we talk to our PBC patients, we should always ask about itching, dry eyes, dry mouth. I don't go down the vaginal issue directly, but I get there indirectly. Itch and energy. Those are the kind of like the 4 pillars we have to be thinking about, because there's this unexplained chronic fatigue in patients also that's very important to patients. So the dry eyes, every patient with PBC should get an eye exam yearly, and the eye doctor can measure tear production and look at the surface of the eye and determine if they should be on eye drops or should have their little canal that takes the teardrops from the eyes into the nose, if they should ligate that. And they've actually done that for patients. They do a little bit of microsurgery there. And that keeps more tears in the eyes as opposed to draining out of the eye. Oral dryness is bad because of accelerated dental decay. Every patient should be every day doing what's called the 5-step dental cleaning. And that is flossing, brushing, scraping the tongue of their, with a little tongue scraper that takes a lot of the bacteria out of the mouth. Mouthwash, super important. And I use mouthwash, this step 5, is one of the spray dental devices like you would have in the dental office. You can buy one for a small amount of money, put it in your bathroom and irrigate your mouth at least twice a day. So 5 steps twice a day for oral. And then to increase salivary output, there's some types of non-sugar candies that stimulate saliva output, but they don't rot your teeth, which is important. And then vaginal dryness can be helped with different types of hormonal therapies, low dose, even local hormonal therapy. Work with your primary provider or your gynecologist to come up with a solution. So that's the story on the dryness.
Perfect. Thank you so much. I appreciate that. We've had a couple of last minute comments, so we're at time. Very quickly, if I may. So somebody was diagnosed in 2017 with their PBC. They also had alcohol-related cirrhosis. Their fibroscar went from 32 to 9. So first off, well done you. That is absolutely awesome. I'm incredibly impressed and happy for you. So you've done that with giving up, with exercise, with general good diet. Does this mean a more normal life expectancy now?
Well, it does. If alcohol, it appears in this general clinical scenario that alcohol may have been dominant, and reversing liver disease off alcohol is very common and can be documented with liver stiffness measurement. And if it comes to no alcohol and it's just PBC, that disease will probably progress a little bit more slowly. But that person has to be on urso because they have PBC. And if their liver disease reverses and then reverses again, getting worse, they need to be on second-line therapy. This may be time to do a liver biopsy to see how much PBC activity there is, or is it residual from the alcohol effect. I still have a low threshold to biopsy my PBC patients because it adds so much information.
Okay, thank you. Very last question. Can bacteria like Cryptosporidium get ALP or ALAT to peak?
Cryptosporidia is a water contaminant you can get in a variety of cities. I think the last big outbreak I heard about was in Moscow and contaminated tap water. It's quite rare in the US, EU, UK, but there is a risk. It's mostly seen in people with HIV with really suppressed immune systems, but it can cause biliary disease and look like PBC or PSC, high liver enzymes. But it's very treatable, very reversible. And if a patient has Cryptosporidia, they work with an infectious disease doctor to figure that out.
Okay, perfect. Thank you so much. The person with the Parkinson's related cirrhosis has come back saying, I'm not sure if I missed the answer. You did miss the answer. And the answer is that we're not aware of any link, but we're happy to go and have a look at that and come back to you. Other than that, Professor Bob Gish, good morning to you, sir. Thank you so much for your time today. A wide and varied session. What a path we took today. Thank you.